everyone, so we're going to go through pterygium today, also known as surfer's eye. So never actually say this to your patients, but pterygiums can look pretty ugly sometimes. Aside from the cosmetic concern, they can cause other issues like symptoms of dry eye. So their eyes might look red or feel gritty and sore if the pterygium is quite thick because of the friction that it causes between the eyelid and the pterygium. You'll often find that they complain that their symptoms are worse in windy environments, or that their eyes look worse in the cold, because that can sometimes cause the pterygium to inflame a little bit. 99% of the time, they're nothing to worry about. They're just a fibrovascular growth on the bulbar conjunctiva, which is why they're white and red. They can happen normally because of long-term exposure to UV, dust, wind, and dry climates. They kind of grow in a triangular shape with the pointy part nearest to the cornea. They're usually bilateral, so they grow on the 3 and 9 o'clock sides of the conjunctiva, where there's more UV exposure. But normally they're worse on the nasal side than the temporal side because the sun bounces off of the side of the nose and it reflects back onto the nasal side of the conjunctiva. Pterygiums can slowly grow larger, but the largest I've seen is where it's encroaching 1 or 2 millimeters onto the cornea, so a bit like in this picture. When it grows onto the cornea, like the second one, sometimes it can change the prescription because it's physically changing the shape of the cornea. Because they grow on the sides of the eye, where there's more sunlight, they can flatten the sides of the cornea, which makes it steeper horizontally. So it can shift the astigmatism towards a 90 degrees axis. Most of the time you'll still be able to get 6/6 VA, assuming that everything else is healthy, because a lot of the time the astigmatism is regular astigmatism, so it can be corrected with a SIL. In all of these really common cases, which you'll see loads of in primary care practice every day, you can just tell your patient to use artificial tears about 3 times a day, maybe use a gel-based lubricant at night so that it lasts longer and keeps the eyes hydrated at night. Cold compresses for comfort, making sure that they use sterile water, so boil it and then cool it down, or they can just get an eye bag to put in the fridge. They only cost about a tenner and they're reusable, so they're less hassle. Also, tell them to protect their eyes from the sunlight with sunglasses and a sun hat to reduce the chance of progression. If the pterygium is pretty noticeable, I'd also tell them that very rarely it can grow into the window of the eye or the cornea and change the prescription, so if they notice any vision changes, then they should return for assessment. If the pterygium looks acutely inflamed and the patient is getting increased symptoms, you can actually refer them to the GP for a course of steroids or non-steroidal anti-inflammatory drops to reduce that inflammation. Up till now, everything about the advice has been about making the patient feel better by relieving their symptoms and making sure that the patient is protecting their eyes so that it doesn't get worse. Sometimes, though, it can be so bad that it comes onto the cornea to the extent that astigmatism that's produced is irregular astigmatism, so you won't be able to get the vision great with specs. It can even get past the pupil margin and threaten the visual axes, like in some of these photos. These cases are pretty rare. I've not seen one yet, but they'd be much more common in those people who get loads of UV exposure. So maybe patients who work outside, like gardeners, builders, farmers, or people who have lived abroad in lovely warm climates near the equator, and also older people, because the older you get, the more UV exposure time you've accumulated. If your patient's pterygium is bad, then you can refer for management by the ophthalmologist. They might do things the GP would do, so things like give steroids or non-steroidal anti-inflammatory drops to reduce inflammation, or they might cut it away. Broadly speaking, surgical incision is done in 2 ways, so they either cut it away and then close the conjunctiva and leave it to heal on its own, or they cut it away and then they do a conjunctival graft by taking a piece of the conjunctiva from the superior conjunctiva and then they patch it onto where the pterygium used to be. They take it from the superior conjunctiva because that's under the upper lid and it's had the least UV exposure because it's protected by the upper lid, so it's normally healthier. The second way with the conjunctival graft means that the pterygium's less likely to reoccur, whereas the recurrence rate for the first method is quite high. According to the College of Optometrists guidelines, you can do a routine referral to an ophthalmologist via the GP if the pterygium threatens the visual axis, induces irregular astigmatism, is chronically inflamed, or is cosmetically unacceptable to the patient. Personally, I'd refer all of the patients in those categories, but with the cosmetically unacceptable lot, I'd make sure that they're aware of the risks and the benefits to the surgery, and that they're aware that there's a small chance that despite that surgery being done, it can still regrow. Okay, so when you look at a pterygium, you'll notice that the body of the pterygium is here, and then the head of the pterygium, so the pointy part, is here. Sometimes there's something called Stocker's line. Now this isn't always there, and I can't remember ever seeing it myself, but if you see this line just in front of the head of the pterygium and wonder what on earth it is, you'll now know that it's a line of epithelial iron deposits. I've never seen it before, so I think it might mostly be in the more advanced situations, but apparently it gives you an idea of the way it's going to grow. And I don't want to confuse you too much by talking about a pinguecula, but for some people, they can get easily confused between the two. So, just really quickly, your pterygiums are a bit flatter than your average pinguecula, and they're also triangular in shape, whereas the pinguecula will be more circular and a bit more raised as well. The pterygium also will be a little bit redder than a pinguecula because they've got more blood vessels, and the pinguecula is more yellow. Sometimes you can have both at the same time, which can be confusing, but the more patients you see with these, the easier it will be to recognise them. And that's it. If there's anything in the video that you have questions about, or even any topics that you want to see videos for, then leave them in the comments down below. Thanks for watching this one. Remember, you can follow I'm an Optom on Instagram, Facebook, and also listen to the podcast. See you later.